Hello, everyone. Thank you for joining us tonight for Doctors in Politics Tuesday Talk. We continue to bring you the most relevant voices that we have in medicine through our COVID-19 updates. And we are in the background continuously trying to recruit and train at least many progressive physicians to hopefully run for public office at every level of government in hopefully 2022. Tonight's Facebook Live on COVID-19, we have today Dr. John Evankovich, who's a pulmonary and critical care attending at the University of Pittsburgh Medical Center. And he's been on the front lines of the ICU, and he's also been in the lab researching lung injury from COVID-19. He's going to speak about the challenges of learning, treating, and educating about COVID-19. If you have any questions throughout the talk, feel free to post them in the chat, and Dr. Evankovich will be more than happy to answer them. But otherwise, the floor is yours.
Hey, thanks so much. And thank you for the invitation to kind of chat with everybody and do this. If at any point people have questions or want to jump in and ask, please do so. I don't have any slides, but I can tell you a little bit about myself, about my experience over the past year, the things I've learned and the things that I'm focused on kind of going forward. So as you mentioned, I'm a pulmonary critical care doctor in Pittsburgh. I spend my time rounding in the ICUs, and our experience here in Pittsburgh was probably different than a lot of areas in the country. When kind of COVID first emerged in the spring, our region was relatively unaffected at first relative to some of the other places that got hit hard. We had our batches of cases, but we spent a lot of time, I think, in the hospitals kind of preparing and not knowing what was coming and facing kind of weeks of uncertainty. And our kind of spring, I think, for the most part, was characterized by this kind of, some COVID patients coming into the ICU and what we would call a first wave, but also a very low census of non-COVID patients in the hospital and in the ICU. So it was kind of this weird situation where we saw other places around us kind of filling up and being overwhelmed and going through these nightmare scenarios, and us kind of being there but having space, and also seeing the hospitals with a lot fewer patients in general. And I was kind of there in the ICUs that time. And I think that was really kind of a scary and kind of very odd time, because there were, as you can expect, a lot of unknowns. But I think one of the things that might have been different is that the places that I worked actually had a lot of time and a lot of ability to prepare for some of these things. So my COVID pods that I rounded in had 6 to 8 patients, and we had, nursing ratios that were 2 to 1, like you'd have in a regular ICU. And there were a lot of questions about, like, as we're waiting for a test to come back, can we put somebody on BiPAP? Is it safe for the other people in the hospital to come and, do an echocardiogram on these patients? Can we get tests that we would normally do? What do we do when we send someone off the floor to get a CT scan? And in a way, kind of having, having the experience of not having kind of a capacity surge, I think allowed some of those questions to be worked out on a hospital by hospital basis, but also, gave me some time to think and reflect and think about those type of things. So I think that was certainly a little bit different. But I think one of the things that quickly really set in to me was, just how different it would be or would have been had that experience been different. How did we get to the point where, we're really talking about ICUs that are overflowing, that there are more patients waiting for ICU beds than there are ICU beds and providers. And to me, that was so unconscionable and so, so scary. So, I really, thought that was the limiting factor in terms of, when things could get really bad. So that's kind of how, it started for me. And I think for everybody, or at least for kind of the northern part of the country in the summer, we had ebbs and flows. We had a little second peak in July, but it was still nothing, super severe. And again, I got nervous again, looking at the trajectory of cases in the summer, about, how much is too much, how many cases in the community mean that the ICU is going to be full and we're going to be converting our step-down units to ICUs. But luckily, there were some restrictions, some targeted things that happened, some community changes, some behavior changes amongst the people in the region that I think, truly contributed to stopping, that from happening. In saying all of that and where we're at now, I think we're in a different spot here, and without having qualitative numbers to say this, but I think that the relative kind of serenity of the first two mini waves in this area has made it a lot harder to get full buy-in from everybody about what's happening, what has happened in the past 2 to 3 months. And that's been, very challenging to kind of have to continue to hold that message about how serious it is, and, what we see in the ICU, and telling and asking people, to continue, making these sacrifices that are really, really tough. Not seeing family, jobs, and maybe asking people to go to work in places that might not be as safe as they should be because of the level of community spread. So I think that's really been, very, very challenging, to be in the COVID ICUs, seeing how destructive and how particularly horrible this particular virus and mechanism of lung injury and mechanism of kind of multi-organ failure manifests, and then also realizing at the same time that that really showing that and seeing and getting that to change people's behavior is really tough, and that's been kind of a tough pill to swallow. So maybe at this point I could
I'll share a few questions. Yeah, sure.
Absolutely. Please do.
I don't know if do you see one of them right here?
Yeah, the challenges around social media and COVID, and a couple stories of the patients that stick with you. So, yeah, I can start with maybe the patient story. So I think some of the hardest stories have been partners, spouses. In the summer, when remdesivir was first approved, it was a lottery in our system, and there was a husband and wife, married decades, that both got admitted to kind of a rural hospital, and both got put in the lottery. One received the drug, one didn't. And it just so happened, and I think it was probably more just, I don't think it was really the effect of remdesivir, but the person who got that drug got better and discharged, and the spouse got deathly ill and had ARDS and multi-organ failure and was on CRRT for a month, and then had sepsis and back. She was in the ICU for months, and they were in sitting with that family multiple times, talking through how this went. I could see, how hard it was, not only on the patient, but on the family that was dealing with this, and really the spouse who almost had like survivor's guilt in getting this drug that was randomized in a lottery. So I think that's one story that stuck with me. A second story that also involved, a spouse pair in their 80s. Again, both admitted to the hospital, and actually were okay for the first week of their hospitalization course, and had everybody, including them, hopeful that things were going to get better and that they were both going to be discharged home. But it turned out that they both got really sick, and within 3 or 4 days of each other. And we actually had a situation where one was in the ICU, on the vent and proned, and was in multi-organ failure, and it was clear that that it was terminal. But there was hesitation in bringing his spouse down to the unit because of how unstable she was. And when we arranged for that and made it happen, the hospital, God bless them, and all the staff that did that, it was a heroic effort. The spouse declared that she no longer wanted treatment immediately after her husband passed. So seeing that happen, which is not typical of what I think most ICU doctors' experiences are on a daily basis, and seeing that, and then moving on to the next thing while someone's calling because someone's unstable it's a lot. It's traumatic, for the family, but also for the people there for doing that. So those are certainly two stories that have stuck with me, and out of many. The second question about social media. So, so one of the things I would say that I was very not active on social media pre-COVID. But in March, when this was starting to heat up, it was clear to me, very, very clear to me, that the people that I cared about were looking for trusted messengers in talking about this. And I kind of just took that and decided that I would try to do that for the people I knew. And like I said, this was not somebody with a big social media following, but I learned a lot through that experience, and I delved into literature that is out there, from talking about how do you talk to people who are that don't believe in climate change, or that really have kind of like a ingrained hesitancy to believe things that I think as physicians and as people in the scientific community, we kind of take for granted that are real and that are true. And I've been really surprised, actually, at how many people that I would see on social media that I thought, without really interacting with them, were misinformed, or were really into something that into the conspiracy theory side of all of COVID or something. And after seeing something that I said, they just said, "Wow, I just never saw that before." My social media feed, what's being inputted into my kind of information world was just not any of that stuff. So can you tell me more about it? And it was really, it was eye-opening to me, actually, to hear that from people. And I think it really ties in with what I'm worried about and what I'm focused on going forward, is that I just feel like the most important thing to do is to get buy-in to get this vaccine. And this keeps going, and we see stories of people that are hesitant to take it or refuse it on the first round. That is, I think, really super concerning. And I found with again, my own circle, which is not 50,000 followers on Twitter or some big thing, but just in my little circle, I've had dozens of people that I haven't talked to in 20 or 30 years send me a message and say, thank you, because either I just didn't know or I was on the fence, and I have it's been eye-opening, and I think all the cards are kind of stacked against us. I know that's kind of weird to say, but I don't have targeted ads on Facebook. I don't have our health systems and our employers and the people that we work for aren't out there trying to get people's attention to change their behavior to buy some product. It's a vaccine alternative or something like that. So I think people's attention has not necessarily been on people that can deliver a message about the vaccine that is honest, that is true, and that acknowledges the uncertainties and the things that show up in the clinical trials, and just be honest about it. So I hope, and I've been really encouraged actually by seeing fellow healthcare workers and people just in a way putting themselves out there to show people what they think about it and why they want to do it. And I think at this point and over the next couple months, there's really nothing more important than that.
So I'll leave you with one last question here, and it's if you have one message for our patients that they haven't heard, what would you say to them?
Yeah. I think the one thing that I would say is that we can't get out of this if we're acting on bad information. So if there are people, patients, people in the community, people who have concerns about this vaccine, if you make a decision based on bad information, which could come from a variety of places, but it's all over the internet, it's all over the Facebook feeds and Twitter, and some of it is malicious. But if people are making decisions based on bad information, it's going to have a real world consequence for all of us. So I hope that efforts like this, and I thank you for doing this and for putting this together and for getting these, for having all of these chats and to try to lift the voices of people that are there on the front lines. I think it's super important to do that, and I hope that people make decisions based on good information.
Thank you so much, Dr. Evankovich. It was a pleasure to have you here, and I totally agree with you. I think people need to make decisions based on facts and the right information, so I really resonate with that message. But thank you so much. You're one of our heroes, being on the front line, seeing the sickest of the sick, so thank you once again. And thank you for everyone for tuning in here today. We'll see you guys next Tuesday. Thanks.
Awesome. Thanks so much.